and welcome to all the panelists who are there with us today. I am Dr. Santwana Vernekar, and I am going to moderate today's session. I would request Dr. Aparna Jairam to please speak a few words as the chairperson of today's session, and then I'll take it forward.
So, good afternoon, everybody, and happy Navratri with this festive season going on. I'm sure it's a wonderful, I think weather and the topic both. So, thank you so much, Dr. J.Jayalakshmi, who I fondly call JJ, and Santwana. And over to Santwana and Dr. J.Jayalakshmi for this session. Let's not delay and have a wonderful session. And best of luck to all of us. Thank you.
Thank you so much, Dr. Aparna, for your kind words. We welcome Dr. J.Jayalakshmi, who is a professor and head of the Department of Microbiology at KMCH Institute of Health Sciences and Research in Coimbatore. A wonderful faculty, a wonderful trainer, a very knowledgeable person, and a very close friend of mine. Today, Dr. JJ, whom we call Dr. J.Jayalakshmi, is going to take the session on pre-examination variables and the quality indicators in microbiology. And from the entire CAHO Diagnostic Division, we welcome all the participants. Over to you, Dr. JJ.
Thanks, Dr. Santwana and Dr. Aparna. And happy to see Ravi Kumar sir, Rajendran sir, Saurav, Jubair. Thank you so very much to all the participants who've connected. And first of all, thanks to CAHO for giving me an opportunity to share a little bit of my thoughts with the entire team today, share with you. And I bring greetings to you all from my institution, and that is KMCH Institute of Health Sciences and Research, and which much in quality. And I'm here to take you through a few of the quality requirements of in terms of microbiology specifically. So microbiologists actually struggle lots in establishing quality in the laboratory because predominantly the microbiological tests are manual. A lot of things are prepared in-house. Quality standards would become a huge concern. A lot of cost involved in terms of preparing, and establishing. But we all know statistics play a great part in any clinical judgment. About 70 to 80% of the clinical management is based on good diagnostic setup. So it is important that we have a good lab and then perform well, and then help the clinical team in handling patients well for the safety of these patients and give good quality care. And for the next probably 1 hour or so, we will look into pre-examination variables and quality indicators in microbiology. Right. So the objective for today's session would be, or the learning objectives as we would call in teaching colleges, is that what are these pre-examination or pre-analytical variables and its impact? Why do I say this? Because it used to be called as pre-analytical variables earlier. So there may be some literature or some picture that I would put which would say pre-analytical, which just means equivalent to a pre-examination. How to address them? What are the quality indicators and what is its usefulness? How to capture and monitor these quality indicators? So it's pretty simple. So you're going to see what these pre-examination variables would be and how it can impact clinical care, because I told you 70 to 80% going to be depending on diagnostics. And if the diagnostic is going to be impacted, then definitely clinical care would also go for a toss. How are we going to address them? Then you look at the quality indicators. That's a part 2 of the session today. And what are its usefulness, how to capture and monitor them, right? Brain-to-brain cycle, or a total testing process, where you TTP. TTP means total testing process. It starts in the brain of a clinician who looks at a patient who's sick and chooses to do a test. So it is his judgment or her judgment which starts up this entire process of testing itself. So in the pre-analytical phase, whether we like it or otherwise, the clinician is a part who would be making a judgment of sending a sample for a test or asking for a particular test. Then comes, getting the patient and, filling up the forms, just once you've identified this is a test I'm going to ask for this patient, you fill up a proper test request form, and then you send to the lab for, you bill it, and then you ask the patient to bill for the test, and then you send this patient to the phlebotomy center, and then they take all precautions and collect a good sample, and this sample is then transported either by pneumatic chutes or by porters or healthcare workers or housekeeping staff, whoever you use in your institution, to pass on the sample to the laboratory. And from the time the brain, the clinician, to the time that it reaches the laboratory, this is called as a pre-analytical phase. Even at the laboratory, there would be a small phase of preparing the sample, before even doing the test on the sample, you go into preparing the sample. So that would be an analytical or pre-examination phase, and that starts the examination, after you prepare the sample, make it ready, and then you put the sample for testing. And once the samples are being tested, then they go into a post-examination phase. In the picture, you would see it as post-analytical phase, is when the test reports are being validated, looked at, reviewed, and then a valid report is prepared, and you release the report to the patient, okay, through the clinician, okay, or directly to the patient and to the clinician. So now it comes into the brain cycle, choosing management of treatment. So this is called as the brain-to-brain cycle. Now, in all of these, there are multiple processes. Somebody is making a decision, somebody is sending a test, filling the test request form, adding the samples, asking for a sample, choosing a particular container, collecting the sample. So there is another person to collect the sample, and then labeling the samples appropriately, of course, and then packing them as appropriate as required, transport the sample, then gets accepted at the laboratory, then gets into pre-preparation, and then the testing. So this whole thing happens. And if you look at it, something can go wrong in any of these phases. Okay, we want it to happen flawless. We want it to happen smooth, but definitely there would be some areas of error. Okay. So if you look at the literature, it says about 46 to 48.2% of errors would happen in the pre-examination phase. And that's what we're going to discuss today, right? So 46 to 68.2%. And if you look at the various errors there, one of the things that they would look for is the blood which is collected going for hemolysis. I am sure most of you in your laboratories also would have experienced or have encountered these kind of errors in your laboratory. So here is this huge numbers. Okay. Now, what is this going to be? Now you're going to add cost to the hospital on the operating cost, because of this error that's happening in the pre-exam phase, there would be an increased cost on performing the test again, etc. So there is a 0.23% to 1.2% of total hospital operating cost that's associated with this pre-examination error that happens. So just look at the numbers and look at the cost that's going to be involved. Now, 1/4 of these pre-examination errors leads to unnecessary investigation, okay, or inappropriate patient care. So you are going to add more tests because the clinician thought of something and he sent a sample, and because of some error, it was not so. So he asked for an additional test, which was not required. Or he may go in for a radiological examination, not laboratory specific, can be a radiological test or examination that is not required. Or the patient who is now denied of a therapy or an intervention which was which was required for them, now not happening. So this is the problem that it would have, right? So it's a huge thing, and we need to work on this. Now, what are these pre-analytical or pre-examination variables? It refers to any and all procedures that occur during sample collection or prior to sample analysis. So the entire process from ordering of a sample to initiating an analysis on the sample that has been collected, the entire phase is called the pre-examination phase that I mentioned to you. Now, this could have two types of variables, two types of things that could influence this sampling process itself. One is an uncontrollable variable, which means we don't have any control over it. It could be the age, it could be the comorbid condition in the patient. Okay, so it could be any of these which we have no control of, but there are quite a few of controllable variables, and those controllable variables are those that we're going to look at in some time. Now, what are these controllable variables? Here, I've just also shown you in a picture on what are the things that you would see in the, pre-examination, examination, and the post-examination. Just for the completion sake, you will see, in the pre-examination, you would see for the appropriateness of the test request, that may be a variable. Proper patient identification and preparation, that may be the second variable. Appropriate sample collection, okay, that may be the third variable. Handling and transport of the samples to the laboratory, that may be a fourth variable. Centrifugation, pipetting, aliquoting, sorting and storaging of samples may be our fifth variable. But if you look at the others, it could be, for example, in the examination part of it, calibration is one variable. Quality control that we do on both the internal quality control as well as the external quality control can be another variable. Test performance itself, the measures that it would do, okay, that could be the variable. Okay, so it could also be in the post-examination phase. It could be the results, okay, the error in the results that can be there, okay, or interpretation of the test reports. That's not interpretation of the test results. So these could be the variables that you would see in the post-examination phase. Okay, so let's focus on the pre-examination variables, the 5 of them: appropriateness of test request, proper patient identification and preparation, appropriate sample collection, handling and transportation of the sample to the laboratory, centrifuging, pipetting, aliquoting, and sorting of the samples. Right. Sorry. I'm so sorry. Okay. Now, what are the concerns if it's a microbiology lab? Of course, all laboratories have variables. It could be the biochemistry lab has its own set of pre-examination variables. The pathology lab would have its own pre-examination variables. But what is unique of this microbiology lab? Like any other laboratories, here also we would have those samples which are patient collected and those which are healthcare professional collected samples. Now, the patient had to be educated on collection of sample, because we want a particular type of sample material that need to be collected for testing. And similarly, the healthcare professional need to be trained. It could be the phlebotomist in the laboratory, or it could be the nurse in the ward. And some of the samples may be collected by a clinician or a doctor, like, for example, a lumbar puncture collecting the CSF sample, or a synovial fluid that you collect. So here you have different categories of people being part of in the sample collection. And this sample collection has to be done prior to antibiotics, because you're going to see organism. And if the patients have been already on antibiotics, then you're not going to grow this organism in culture. You may not be able to see them. So you think everything is fine when it is not. So you need to have have the patient free from antibiotics. But me being in a tertiary care or quaternary care hospital, definitely the patient has gone for multiple levels of treatment at different levels of hospitalization, and then comes to us, and we do have this concern of the patient already being on antibiotic, and that would be a worry for the microbiologist. The other is you have microorganisms everywhere. You have them all over, outside, also on us. And those which are on us could be the commensal flora as well as those pathogenic flora. Now, we are worried about the pathogenic flora, and we need to identify them depending on the site of the infection that you're looking at. So you need to be very careful in collecting these samples, because if the person is not very sure, maybe the patient or the healthcare professional, we may be collecting the commensal flora, a contaminating organism, instead of the pathogen which is missed in amongst the large amount or huge volume of contamination flora that's been picked up. Now, also we have to worry about the variable, which is the viability of the organism. So if you're not going to choose because these organisms, each one of them have different lifestyle, different ways of multiplying, different ways of existing, and so they are going to be living in different specimens for different periods of time. And if you put them in different temperatures, they're not going to survive, or they're going to be doing well. So they are very approximating in requirement the samples for specific organism. So we need to look at how can we keep this organism viable, this microorganism viable, which would be again another area of concern for us. So these are definitely concerns for microbiologists. Like I mentioned to you, except the sample, everything else has to be sterile. It has to be aseptically collected, and brought to the laboratory as early as possible. And somebody knowledgeable has to guide them through the process in receiving the sample and start processing the sample. So these are the areas of concern that we would have in a microbiology laboratory setting. But thanks to COVID, and which has initiated this huge process of accrediting laboratories for performing COVID tests. Okay, the last 2 years has seen the biggest transformation, or revolution, I should say, in laboratories where the labs have been equipped for molecular testing, and they have been also been exposed to accreditation processes, because without an accreditation, the labs cannot perform molecular tests for the population that they serve. And so they may be forced initially. Now they all understand the terminology well. So no, lot of microbiologists, lot of lab professionals, lot of technical staff, everybody understand lot of terminology is much better. They understand accreditation, and this accreditation has also has moved on to just not being in the molecular sectors, but also being they are able to follow a similar for the other divisions in the microbiology as well, maybe in bacteriology, in mycology, parasitology, all of these sections as well in its performance. So thanks to the entire thing that happened, and we're glad. But and it's also given in confidence to have things better. So I have the more confidence, because I know this audience is already aware of a lot of things that I'm telling you today, right? So I'm going to take you to the first variable, or the first issue that we would have in pre-examination that I mentioned to you, the appropriateness of the test request form. This is an example or a sample request form by WHO, and I love to put this slide very often times, because it is so very comprehensive that you can use it and you can modify it to your own lab requirements by adding your lab details, etc. on top. Okay, so the clinician needs to fill up the test, but if he has made a wrong choice, so inappropriate test request, suppose he's made or she has made a inappropriate test request. What could this inappropriate test request mean? It could mean that instead of asking for a specific test for hepatitis, you've asked for another test. Instead of asking for anti-HBC IgM antibodies, you have asked for probably HBE antigen. Okay, so, or if you've asked for an IgG antibodies instead of an IgM antibodies, or you've asked for you've set a sample in an asymptomatic patient. Okay, so these could be areas where it may not fit into the appropriateness of the test that has been requested. Okay, so there would be either because of the knowledge deficit in the person who's marking up the test, or an accidental tick to the next which is in the line. Okay, so there could be inappropriate test because of these two things. And while documenting, it is important to fill in parameters like patient details, which requires the patient profiles of name, address, age, gender, etc. The requester, because you need to know whom we need to contact in case there is something growing or something we need to discuss regarding the prior antibiotics, the current condition of the patient, location of the the site of infection, the site of infection, all of these, current prognosis, long time of hospitalization, whether it's been on a catheter or not. So all of these. Okay, so let me give you an example of what happened in my lab today. Okay, there is a sample that's reached my lab yesterday evening. There are five bits of samples that have reached. Okay, and with a single request. And the technician, being a new person, has received it because found them with a single request, and all of the samples are similar, but they are bottled separately. There are 5 samples being put up. Okay, so this is a synovial tissue that's been sent for culture. So we in the morning, when me and my team of faculty, when we were reporting, we're trying to see what is this, what happened, how did this, where are the other requests, what did it come for, which are the site, etc. So we were worried. So we and this new technician also was little dazzled to know what to happen, and was very stunned by the questions that we were shooting at. Then took courage to say, ma'am, this is all that we've had. So we called up the clinician to find out what happened. They said, no, we found it, found multiple tissues, we put individual bottles, and we have sent. So was it required? Was it required to send in 5 different containers? But because the specimen for the clinician looked different in different sites of its infection, and they have picked it up and they have put. So it would have been good if they have just put it in one single bottle also. And if they are wanting to do additional tests on that, this would be useful. Sometimes we want more samples, doesn't come to us. Okay, we want 2 swabs, for many samples, though swab is not a great sample, but still we want 2 swabs. It doesn't come. But when we don't expect these samples land up. So there is this discussion that is really required, but it's important that the clinician writes relevant clinical information. When I say relevant clinical information, it means that when a sample of urine is sent, the clinician should not write the patient's clinical condition is admitted with stroke, or so here we have no clue on why are you sending a urine sample for a patient stroke. Maybe the patient is on catheter for a long time and then now removed, or has an infection, or with symptoms of UTI, and then you've sent it. So the clinical relevant information should be specific to what is the sample that is being asked. Okay, the type of sample, and you tick the sample, additional information that may be there, antibiotics that is given. Okay, suppose if it is a sample that does need to be collected. Okay, so the sample collection, person's name, date, time is important. Why? Because we could go back to asking. Okay, so at least the date and time, if not the name, but it would be good to have their initials so that we know to ask, you know whom to ask if there is a query. Okay, diagnosis in the requisition form will help in ascertaining, site-specific pathogenesis. So we know what additional media we need to put up, what additional things, organism we need to look at, what additional, microscopic stains that we need to do to identify whether you're looking at a case of nocardia. Then I would want a 1% acid with the modified ZN stain. So this is something that I need to. Also, I need to know whether the patient was prior on antibiotics, so I can think of, okay, what would happen? What would it grow? Would it not grow? Then I can be able to identify. Then also is the antimicrobial susceptibility testing. Okay, it would be useful for or help me in choosing, or us as all microbiologists, on choosing the most appropriate antibiotic discs that we would want to put up, or antibiotic susceptibility testing that we would want to for these patients. Now, what is additional that's required when a test request form comes is consent. Consent in microbiology most often focuses at HIV testing. And if there is a HIV test, then definitely it should come with a consent form. And this consent form should be so specific that it it tells clearly that this is a HIV consent form which has followed which is a consent that has been taken after a counseling or a pre-test counseling, followed by this consent being given to the consent being given by the patient. And what I see many times as an assessor would be the consent form would always have, not always, many of the consent form would have a witness signature. I'm sure all of you know that HIV is a test which is very confidential. You don't have a witness. You could have a guardian signature in certain, or the person consent signatures only in certain cases, like when it's a child or the patient is is not mentally well, or if there would be if the patient is in a not in the state of mind to give, or to give the consent. Okay, only in those situations, very few, which you will describe those also, and only in those you would allow somebody else to sign a HIV consent form. Otherwise, it's going to be the patient himself or herself. Okay, so that's important. Now, how complete is this form is something that you need to look at, because sometimes you will see a mark here, mark there, a barcode stuck there, which means everything else is there. There's a barcode, you capture, everything comes. But what will not come is the clinical history and details, the site and side of sample that's being collected, etc., the type of sample, etc. All of these would not be coming. So you need to write all of them. You have to sign ideally with a seal and signature. The next is garbage in, garbage out. If you have, if your sampling is not good, you can't expect great results of that. We currently in the laboratories may be well equipped with automated systems for, slide preparation, slide staining, okay, media streaking, okay, and then you can also have them to read. You can also have them to, to identify the organism. You can also have them to do the sensitivity and all of this. If you're going to do on a wrong sample or a purely collected sample, the whole exercise is going to be a waste and a lot of money going into the drain. So you need to understand that your sample collection is going to be the priority in all of these cases. So proper sample collection, the second variable that we're looking at is proper sample identification of the patient as well as preparation. Now, many times you will have the patient samples mislabeled, okay, because the sample will say a name, Savita, I'm just giving an example, and the request slip would say Sangeeta, or it could be totally different, somebody else, a male patient sample collected. So it is a practice in some places still, and in a high load working areas or clinical areas, with very limited workforces, maybe nurses or phlebotomists, they pre-label the tubes and keep them ready, thinking that it becomes easier. So sometimes they don't put it on the right one, or don't put the right label on the samples, so they don't match them. So it's always good to match your samples with your test request forms, and that will be the best things to do. Okay, so the identifiers don't match, that's going to be a problem. Second is sometimes you will have unlabeled samples. The requisition comes with a sample, maybe in a pneumatic chutes, or the person carries it and brings it to you, and then find that the sample does not have a name on it or does not have any detail on it. So you ask them, they'll say, we sent 2 samples. We don't know which sample is which one. Now, what do? You have to waste both samples that were collected. Sometimes if it is a precious sample, it's going to be very difficult. Timing of samples are so important. Sometimes we well time the sample and we collect the sample. So those samples, it's going to become, waste when you now can't use that particular sample at all. So you will have to have your sampling, labeling done appropriately and match it with the test request form. Of course, sometimes it comes without the test request form, the sample alone comes. And certain labs, they process it. Sometimes certain labs would keep it there till the request comes. Now, what happens is that it would be a urine sample and you have left it out for long hours. And here this would, multiply exponentially. And by the time you get your test request sorted out and you brought the sample again back to the processing, it few microorganism has now become significant bacteria in your report. So this is something that you need to be very careful, that even if your samples are not accompanied by a test request form, and these samples, if you're going to be accepting them and await them, or you have a interim area to hold back such samples which are in query, so it is important that you store them appropriately. So this is another something that would be a problem for us in the pre-analytical or pre-examination phase. Inappropriate patient preparation. Like I mentioned to you, it's going to be two types of people doing this process. One is the patient, the other is the healthcare professional. If the patient has not been instructed well, they're going to collect the poor, bad sample because they're not going to prepare the site well, or they don't come prepared. So you ask for an early morning clean catch midstream urine. Okay, so and you've not told the patient what this would be, so then it's not going to help the patient, or you can't get the early morning sample from this patient. Okay, so what is your alternative in such situations? Suppose you have this patient there, and then you will you collect the sample and you leave it there. So this is a problem. So you need to have your patient preparation done well. The best example would be on blood sample for blood culture collection. So it's important that you decontaminate the site very well, and then appropriately and not palpate it again. So if you are in an assessment, you ask somebody or you watch somebody do, so they will say, ma'am, I was tensed. I saw you and I got scared. So that is a reason. Otherwise, I usually don't do this. But you have to be very careful, and you have to tell people whatever happens, you are required to do these things. Don't do this. So your cleaning would be with 2% chlorhexidine if that's your policy that's written down. And if you're going to use a swab, circular, and you clean it for 30 seconds and then discard, take another swab, clean it 30 seconds and discard. And then, you also collect the sample, appropriate amount of sample. So that's another thing. But here, preparing the site for the sample collection, very, very important. So this is another area where you would have so many errors that's happened in the hospital. Okay, and many times you totally miss out. I can tell you of a case when in my early times of my profession, there was a patient who tested positive for HIV. Right. So the sample also we repeated and as per the protocol, and turned out to be positive. And didn't look at the report. The report was released. Okay, the technical staff gave out the report and it was done. Then the patient was a 14-year-old boy. Okay, I'm telling you 20 years back. Okay, a 14-year boy, and the whole family panicked, and the ENT surgeon also panicked. He came running to the laboratory and he said, "Can you tell me? Is it true? Is this thing? And I have handled this patient, and I'm going to do a procedure on this patient tomorrow, and that is the reason why I, tested him for all that." Then he said, of course, there was another patient sample. Okay, so what has happened is they have exchanged, or they brought it at the same time, and the labels were exchanged. So the testing was done, and we'll never know. Okay, why can't a 14-year-old not be positive for HIV, isn't it? So it is important that we double check when there is a query, but this is only when you have such situation. But otherwise, always good to match at least what's with you, your test request form and your samples, right? The clinicians have to be given this, they have to have this culture that is sending the samples, before starting an antibiotic. And definitely very, very useful, and studies have proved many times and more. And it's very important that they know. And of course, we need to have these cultures in place for us to also, collate antibiograms and give. So starting an antibiotic and giving a culture would not make any sense. And starting an antibiotic, not sending a culture, is also not useful. So important to send a sample for culture, and that's prior to the antibiotics. Now, moving on to the third variables that we have, that is appropriate sample, choice, volume, and timing. Okay, So patient collected sample, I've just taken examples of few. There are many more. Yeah, patient collected sample, it could be urine or sputum. So if it's a patient collected sample, then you give a clear instruction. It has to be bilingual. So how often do we have somebody telling the patient how to collect these samples? Only when you have them growing in your cultures, you will say, this is, all the urethral floras are growing in this site, not a good sample. Your wets show a lot of epithelial cells and not a good sample again. So it is important that you have the patient collected sample done in a way that you have instructed the patient on how to collect the sample, what sample you would want, what volume is expected of them, and pre-label the containers and give it to these patients and, collect them and bring it as early as possible. And the patient also makes a note of when the sample was collected. So it becomes easy for us how long we can keep the sample outside in case there is no option for storing the sample in refrigeration. The other is the sputum when you need to collect for, for routine cultures or for tuberculosis. When you have a patient with suspected, again, this is just an example. So it's important that we tell the patient how to collect the samples. And, even if you say the early morning sample or a start sample that you collect, this where you would want them to go and collect the sample, where they should not be collecting the sample, how important it is to just rinse them off well, and the productive cough is what we have to. So many times you will have only saliva coming in the samples. So in the sample that being sent to you. So this is something that it will worry us, because you are putting all your efforts, all your culture media and everything is going for a waste because you are processing an inappropriate sample. Okay. When a healthcare professional collects samples, they could be collecting urine samples again, by catheterized urine or a suprapubic aspirated urine sample. So they need to know how they need. So they cannot be collecting in the Euro bags. Catheterized patients from the Euro bags should never be collected as a sample. They cannot be collecting the catheter tips. Not a good sample to be collected. So they need to be given this knowledge. And blood for culture, the the more the volume, the sample, the better. Minimum is 8 to 10 ml would be ideal for collection. If it's an adult, 1 to 3. If it's a pediatric, so if you have a paired collection of sample in 2 sets, that will be the best to do. Okay, so it improves your isolation rates as well. So the volume is also important. So we need to capture that, whether the volume is right, either you measure it or weigh it accordingly. You can identify whether the volumes are right. Okay. There would be a huge site of a surgical site infection with a gaping wound, etc., with purulent pus, but they will take a small nip of swab very close to the skin surface, and they will send one dried swab to the laboratory. So whenever a tissue is available, always ask for a tissue first, and then would be an aspirated pus would be the better sample than a pus sample. Pus swabs as a last alternative only. Many times, even for a fungal cultures, you will get only swab, and that too a single swab. I think all microbiologists understand this difficulty, where you need to put them for culture, and then you try to see the smear, either there's nothing there or it's totally a dried swab. So single swabs never adequate, and many times you will only have a single swab coming, and it's a dried swab. Sometimes special samples, like patient, the healthcare worker who's a doctor collects a sample in specific areas, and they have to bring out the sample and send it out as early as possible to the laboratory for processing. And sometimes it could be those anaerobic samples. We may not be not all labs are readily equipped with processing of anaerobic cultures. So it's important that the laboratories are announced earlier about the requirement of anaerobic cultures for a suspected anaerobic infection, and then ask for the samples, and use anaerobic culture transport medias or transporting systems for sampling when they can be brought in. Or the molecular testing samples, of course, it's important that the type and volume. I'm sure a lot of you would have had experiences of sampling errors leading to negative COVID tests, right? Most labs, we all do COVID test, and you will see somebody with good symptoms exposed and positive, and you do the first time, they would be negative, then the person goes elsewhere and he gets it tested positive and comes back and tells you, I got it tested elsewhere and it turned out to be positive. Maybe the same day, this next day, because ma'am, I wasn't very convinced, so therefore I did. There may be one experience like that. I did have some experiences, like somebody telling me I did first here and then next day it was negative and then it turned out to be positive in another lab. So it is not just the lab that's a difference, it's also the material used for swabbing. Okay, now everybody uses the appropriate swabs for nasopharyngeal, oropharyngeal collection because it comes as a set. But the way they collect the sample is the problem. The technique in which they collect the sample, that's a problem. So your sampling is not collecting the right sample. So therefore, the organism is not getting amplified in your specimen, and then that's getting negative. Sample collected well, if they're not being transported in appropriate temperatures, again, it's going to be a waste because your CSF samples can have fragile organism which does not survive, temperatures in cold. So if you have put them in colder conditions or in the refrigeration accidentally, so blood, body fluid, and CSF never refrigerated. Similarly, molecular test samples need to be refrigerated, or it has to be taken as early as possible, or in 2 to 8 degrees centigrade and brought immediately to the laboratory. That would be the best way of isolating these samples. So it's important that we choose a sample. The choice of sample should be right. The collection methodology should be right. The people who are doing it is trained to do that. The volume that you collect is adequate and appropriate for sampling, more so for serological samples. Sometimes you will find this as an error again in when you're assessing some laboratories. You'll find that the lab would mention 1 ml of sample that be collected, but what they would be collecting would be 3 ml of sample, or sometimes 4 ml of sample. But what is the document that would written is 1 ml, and it's be displayed there. Then they will tell me, no, ma'am, that is the separated serum that we have mentioned here, but this is not what we would collect. So you need to be very clear on each sample type and the volume, the timing of sample collection. Okay, and the procedure in which this sample has to be collected and brought to the laboratory as early as possible in an appropriate transportation conditions. Okay. Tissues that's in samples in formalin is never useful for culture, so never be using them. The fourth analytical variable or pre-examination variable would be sample handling and transportation. So you need to transport the sample. I think this is just an extension of what the sample collected was. So collected sample need to be packed and transported appropriately in containers that have a biohazard symbol on them, right? So this transportation, of course, as a variable, you would see that, not being transported in appropriate conditions. And sometimes they will say, ma'am, we always use it. It's just that today we didn't have it. Or sometimes they will be using it that day only, so they have no clue on how to put it. So they just drop the sample inside like that. So you have to be very careful. What is that you are transporting? How it's going to be contaminating other samples that you carry along with it? How do you need to pack the sample so there is a safety of the person concerned as well as for through the transportation process as well? So this is again something that need to be considered when packing and transporting samples, either within the laboratory from the phlebotomy area to the processing area, or it could be from another center receiving the laboratory or passing on to a different location or different country also if you need to. So it has to be transported as appropriately. Sometimes you need to add appropriate preservatives in case you're not able to, keep the samples in refrigeration because your volume is low, high loads of sampling, for example, that you would have with urine samples. So you need to add preservatives so that it stays at least for 24 hours, where it does not allow multiplication and just maintains the viability of these organisms. So sodium azide can be used, and those available containers available. So it's important that they use such. So another NC that I would, or another area of concern that you would see when we're on these assessment would be sample received in the laboratory for urine, they would have processed it, but the sample would have been collected the previous day night and left outside, brought next day morning at 11 o'clock, then processed in the laboratory at 4 o'clock. Through the entire process has been outside and nothing been done, or no mention on that, or there is no rejection criteria defined, nothing. So this is something that is very, very common, very common. Okay, so need to look at the sample, the integrity of the sample that is being collected and brought in. So if you are rigid in in rejecting samples, then you are sure to get good samples for processing. So it's important. We always say, oh, if you reject, then they are not going to send sample to us. Then I think we're wasting a lot of resources. Okay. The other is transportation media, depending on the condition. For example, if it's a watery diarrhea from a different site, from a primary health center, they are going to transport the sample. So you ask them to transport in appropriate transport medias, and then, or in anaerobic, like I mentioned to you, you could have anaerobic cultures if it's expected. So your experience of the previous few months will tell you what you need to be ready with, and there may be some surprises that you can prepare yourself for. But these are the things that's going to influence your testing, because your samples are going to come dead, non-viable organism, and then you are expecting it to grow greatly in your cultures with the best of the system, or you have an anoximate to grow your anaerobic cultures, but your samples were not collected appropriately, makes no sense, doesn't match the requirement. So it's important that we look into these small things, and it's good to walk through the process and see what happens to each one of these samples and where you should be working on. There's the last one of these examination variable, or the pre-examination variable, where centrifugation. Another area of concern. Sometimes you will see, it is centrifuged at RPMs not as per the SOP. It's at 1500 RPM, but your SOPs would be saying 3000 RPMs. Okay, so, and also the temperature at which they are being centrifuged, whether if it's requiring a refrigerated centrifuge, is it there? Sometimes it ramps up late and then it stops slow, but the process the entire process would be for 1 minute or so, and then it's not doing its work well. So you need to look into your centrifugation, whether it's doing well, or you're doing it appropriately as required, as mentioned. Okay. And pipetting, you have to know how well your team is, trained to pipette. That's another area of concern, particularly for all serological tests. And those tests that you do for antibiotic susceptibility testing, when you're doing an MIC, etc., it's important. And also molecular test, of course, where, if you are collecting your sample by, double press and pushing in, and sometimes you would have an air bubble trapped in your pipette tips, and that's going to reduce the volume that's required for taking up the sample. So that's another area of concern. One also would be your aliquoting of the sample. So all these things are happening after you receive the sample at the laboratory, after you have accessioned the sample. Now, accessioning is one great area of control, but not used very well, I would say, because even in those labs that again, an experience of assessment where you see that the labs, their acceptance rejection criteria displayed on the board is very good, but what they're doing in accessioning is poor. Okay, there are labs where, instead of the temperature side, they've written, for the last one whole month, the technical staff has been writing the date. Okay, there is no temperature captured at all. They're not looking into the temperature at all. Okay, but if you ask them, what all will you do? We will look at the temperature. Where is it written? Nowhere. There is nowhere that this temperature has been captured. Nowhere the sample receiving date and time is being captured at all. So there is a date, there is no time. Okay, so how are you going to define your turnaround time? How are you going to capture? Yet another area of concern would be, the sample, when it is billed, automatically becomes a collection time in many laboratories. And how would it be if the patient is asking for a urine culture, and the sample, you have billed the sample, and the patient can't pass the urine, then it takes the container, goes home, next day early morning collects samples and brings and gives it. Okay, so according to you, the sample collection was a previous day, And today the patient has brought in and you have processed immediately, but it will show a TAT deviation of almost about 18 hours or so. How are you going to handle this? The other is whatever time the sample is being received is taken as a collection time also. The collection time and receiving time is also the same. So many systems, when they click into the barcoding or they capture, the reader would capture that particular time at that point of time of sample collection. So when they receive the laboratory at the laboratory, they will have to redo it. Otherwise, it stays as such. So these are very small things, but it is important that you capture it appropriately if you have to get your systems in place and your quality improvement procedures in place as well. So that's another area of concern, this turnaround time capturing. Many labs would have issues. Okay, also is when they have your weekend errors. Okay, so that's another thing that you need to worry. So samples come in when they have to aliquot. This happens in molecular labs, or you're holding up all these samples on a specific day for serological test, etc. So you have to transfer the sample into aliquots, but if you're labeling, you have to be very clear. You have to double check, because if you make an error, you cannot go back again. So double checking somebody else, if there is one person to read, another person to write down, that would be the best thing to do, but that is a good way of aliquoting as well. Then sorting out the samples on what you need to do, where you are going to place them, how long you are going to store them, etc., until they are being processed. Okay, and the temperature in which you're going to maintain them till you're processing the sample, that is again very important. Some of the samples need to be kept at -20. Some of the samples need to be kept at 2 to 8. Some of them, at room temperature, or 37, like parasitic ones and all, you want to keep them at room temperature, and CSF immediately you process, or at 37. So you have to know what temperature you need to, and sort them all out and send a sample for processing. So these are our pre-examination variables. There are many more, including the antibiotics that the patient is already on, and the volume that you have collected, the type of tissue that you have picked up, and the containers that you have transferred, the way that's been brought into the laboratory. All of these could influence your examination. Now, what is the impact of these pre-examination variables? So what is going to happen if these 5 things fail? What is the worry? There is going to be a delay in diagnosis. So there is a loss of critical time. The time that is spent is going to be lost. So there is a very sick patient with meningitis, CSF sent, the sample has got misplaced, did not come with a test request form or something like that, and then it got stuck to be looked for and wait for. By the time the test is done, probably the patient may not survive. So where are we going to document this part of the things that happen? So delay in prompt therapeutic interventions don't happen if your tests are being delayed. Additional tests may be done. Sometimes you need to retest to confirm, or or just retest because these samples are not acceptable. So that's again another issue that you would have. All of these would add cost to the patient. Additionally, like I mentioned to you earlier, operational costs for us also in the laboratories would increase. So it's going to be a huge area of concern safety concern for the patient, management issues, and appropriate timely interventions are not going to happen, and of course the cost. Now, how to mitigate? Training on sample collection and handling. So sample collection and handling, you can train your healthcare professionals, but however, for the patients, you always give instructional cards in a way that they can understand. So read and write, put it down in pictures in bilinguals, and hand over to the patients if it's going to be a patient collected sampling. It's worth the effort that you take to tell them what type of sample that you would want them to bring back to you. Appropriate technology using barcoding or RFIDs, which will capture them, right, and linked with your LIH system, and most automations, where you can, if the loads are very high, it's good to go to places like CMC Vellore, where their pre-analytical areas are amazing. You will see the whole load, everything is automated into the process, and it can even segregate and put them all together and batch them out and send it across. Okay, of course, this is only for the blood samples that can happen, but you can also have some mechanisms of transporting the other samples like stool and urine, the pus, etc. Choose the appropriate material for sample collection, containers, and also for transportation. So all of this has to be done. Adhering to standard guidelines. So follow what is being told to you, and training everybody to follow that is important. And of course, that has to be followed by having writing a good SOP on how to do, what to do, who will do it, and all that need to be clearly written and easy for everybody to follow in simple language. Validating the instrument or procedure that is being used. It could be your centrifuge that you are using, or the instrument that you're using for collection of the sample, or the procedure in which you are doing is accepted and acceptable, right? Have a very strict sample rejection criteria. At the same time, you should also have a clarity of thoughts on those very unique special samples which are very difficult to get again. So working out to choose to find out whether it's the right sample that you have collected. Just because the sample did not come with the requisition slip, you cannot just hold some samples. You could process but document it, considering the criticality of the sample by itself. Then the last one is, of course, monitoring quality indicators, so that you see how many of them are errors, how many of them are, the wrong samples being brought, wrong test requested, incompleteness of the test request form. So all of these could be your quality indicators that you would need to monitor, and that's something that we're going to see the next one. Continuing with mitigation, there are two other things. Of course, there are people who are very proficient in doing this, but some of them very naive to this. There are Lean and Six Sigma principles for pre-examination errors. What does the Lean process look at? It looks at, it walks through the entire process that takes for the entire testing, and you see which of them are wasteful, which of them are useful, and so you hold to those which adds value and remove those which does not. So this is the simple thing. You walked around all the way around to meet that. You just walk straight and then you achieve this. So this you will know only when you stand out of the whole system and watch the entire process, and or look at the process. Okay, this sample collected from here reaches there, goes here. So how do I make it more efficient? Where do I reduce? What all can I put in place to make the system need modification, removal of unnecessary process steps, movement of material or people without a purpose. You don't have to unnecessary waiting time. So all of these can be removed by having a very good or a lean principle, which used to be used in certain car manufacturing units, and now it's applied in various healthcare activities. The other is Six Sigma. This is a metric methodology that focuses on reducing the variabilities. Okay, trying to look at the errors in total numbers and giving them the sigma values. Okay, so anything lesser than 3 would be in a good score of sigma metric. So you count and decrease the number of defects in the process. But once you give the sigma score, you also start to work on, for each of the scores, what are your mitigation plans. So this is I've just put it into a simple line, but of course, people who are interested may go and learn and read more about it. So we're moving on to the next session that we have. That's on quality indicators in microbiology. Now, what is this quality indicators? So the standard UNI 11097 document says these are measured information, which are either qualitative or quantitative, which indicates the performance of a process. It kind of determines the quality of service, identify areas that need further improvement, and it kind of tracks the changes over the period of time. So this is quality indicators. Now, what does ISO 15189:2012 say? It says this ISO 15189:2012 recommends use of these quality indicators for the assessment and monitoring of the quality management system. QMS means quality management system in the laboratory, for timely, accurate results to meet the patient needs. Please understand, all of this we are doing only for the benefit of the patient. So if there are anything that is missing out, if they are not doing something good, that means it is something that we have not knowingly harmed a patient. So we have to take all efforts to see that it goes well on time. Now, what are these quality indicators? Okay, and what does it also encompass? So they are extremely valuable tool for a systematic monitoring and evaluation of laboratory performances, as described by CLSI 2012 document, which covers the critical. We look at the critical areas of the total test performance that you look for. Okay, so in the entire thing, you look for those key points where you have issues or the pain points, and and those are the critical areas. And those things, if you are able to capture them and look at them and start to document them and see how they are doing well and now, so then it will be able to help us to progress further and later. So this is something that you need to have, and it is usually captured in numbers. Okay, so there is a metrics to it. Not all metrics that you capture are quality indicators, but quality indicators do capture metrics. Okay, so it kind of determines the stakeholders' need or the customer's need. Here the customer could be the patient who's giving the sample, or it could also be the clinician who's asking for a test. And this could also capture the operational performance expectation of the laboratory. So in many laboratories, if you look at the quality indicators, they focus on all the areas which would look at the financial cost. Of course, not the ones now in the molecular assessment times, but if you're looking at as a whole, as an indicator for any organization, the focus will be on financial gains or financial loss that would happen. So the focus happens there, but it will be a good mix if you have everything. There need to be a look at the financial gains as well as the errors that would happen, the customer satisfaction, and the overall also. So everything has to be together in this quality indicators that you have chosen as a tool for assessing the laboratory. It has to be standardized. Standardized meaning I do, my friend does, my colleague does, my junior colleague does, the newer person does. They all capture the same way. And then it has to be evidence-based. Okay, I should have some kind of an evidence on why I'm doing this. Why should I be capturing this particular measure, right? So the standardization is an issue lots of time. Yesterday I was in a meeting, and then there was a query that was raised. Said, for a few years from now, there is nothing that's changing in your metrics, in your data that you're showing. It's hovering between the same two lines, okay, of between these percentages. So I don't rely on your data. How can you have a same data through the last 3 years? We have 2 years of COVID. We didn't have some patients during a certain period of phase, etc. How can you? So the person who had captured tried to explain, but it is always good that you have a standardized methodology of capturing. So everybody who captures, whether I capture or my colleague capture or the junior most faculty, junior most technical staff assigned to capture, or quality person assigned to capture, captures what needs to be. So this is a very, very simplified capture tool to do that. Then what you need to do is assess the current system performance. So it's almost like, analyzing what exists now. Then you identify priority areas or those critical areas in the TTPs. Okay, so you see which are these areas that I need to identify, to focus more on. Then you have an action plan to drive improvement in care qualities and outcomes, because your quality indicators will also include some structures, the process, and the outcomes as well. So you will have to look at what actions need to be done when these are required as an improvement for the entire lab quality. Assess progress in achieving the improvement goals. Okay, so you will, if you're moving forwards, you need to have some methodology of assessing the progress as well. So another important thing, I have a friend of mine who's an assessor, Okay, so when we team up to do an assessment, most of the time, this ma'am would always say, Dr. J.Jayalakshmi, I again gave this NC, she says. Okay, so what is this NC? Because your lab defines a quality policy and you define a quality objective also. You say that you will be doing this in terms of patient care, of testing, etc., etc. But you will not have a tool or a measure to assess whether that objective is attained or not. And that is one of the requirement, and it's in the class. And so it's easy for some people. It's not easy. It's a must for some of our assessors to score that or mark that as a non-conformities or non-compliance to requirement. So when you have defined your quality policy and you've written your quality objectives, okay, list them down and then see which of these which are the quality indicators are addressing these quality objectives that you have defined for your laboratory. Right? Now, it should monitor the performance of both. There could be a technical component and the non-technical aspects as well. We'll see that in a while. Okay. It may be defined based on the the quality indicators may be defined based on the errors that we have. My lab has more of this particular error. Mislabeled samples are more like that. So then I choose that as a quality indicator and start to capture them and start working on them and start to root cause analysis, corrective, preventive to ensure that this doesn't happen again. So I have some kind of an intervention in place once it's done. So I also choose this based on the feedback. We are not getting it enough. We are having these problems. The clinician says, oh no, we have our contamination rates are very high. Your isolations are very poor. So this would give us a clue on what could be our quality indicators. May be created and tracked annually. You need to review them. So once you create a quality indicators, need not be the same. Yet another NC that you, not an NC, it's a OFI that we say, this is something that you will see people putting all zeros, all documents of quality indicators will be zeros. Okay, everything is zero. TAT deviation, zero. Error, zero. Redo, zero. Okay, everything is zero. There is nothing, no samples would be rejected. Okay, nothing would have been withdrawn, no error reports released, nothing. So everything is zero. So if it's already a zero and you think you're doing capturing well, stop that and look for something else which is a problem, because there is no lab without a problem. There may be some other process which requires your attention, work on them. So nothing need to be a fixed quality indicator for forever, and that's happening. As long as you're able to capture and able to bring down the values, yes, good. Once you've solved it, move on to the next one that need to work down. So that's something that you should see. Okay, a single specialty also could be done. You can see the same thing in virology, parasitology, and mycology, or you can have them all together, as a single one. Delay or TAT. So your TATs could be specific to virology TATs, your parasitology TATs, and mycology TATs, or you could have microbiology TAT as a whole. And you can also look at it as a whole for the entire lab. So depending on how your lab is functioning, is it functioning as a multidisciplinary specialty laboratory or a smaller facility which does all lab or tests together? Okay, so I'm really fascinated and amazed by the kind of work the labs do all tests together in one area, because being from a teaching institution, we have specified departments, so we work like that. But I'm so amazed to see like some of the technical staff in certain laboratories. They're amazing. They do really such good work. They know all tests very well. They are able to perform most of them pretty much good. Okay, so we could do so depending on the lab, you can choose your own. So you can tailor. Now, does NABL say anything about it? Yes, it says in 4.14.7, it says the lab shall establish. Okay, shall means it should be. Okay, it should establish quality indicators to monitor and evaluate performance throughout the critical aspects of pre-examination, examination, and post-examination processes. The process of monitoring quality indicators will be planned. Okay, so you cannot do just like that. It has to be planned, and it should include the establishing the objectives, the methodology of doing it, interpretation of what you have set to start. Then you should have some limits or some benchmarkings, You should have some action plans on how to go about when things go wrong. And you should also say, how long are you going to do this, capture this whole thing? Okay, your duration of measurements. Everything has to be predefined and planned. So there should be some kind of planning done for your quality indicators capture. It's just not something that you just write something and say, okay, from alt tag done, redo, no, nothing. Yeah. And of course, you periodically reviewed at least once a year. In your note, it also mentions to look for non-examination procedures, and also it looks at establishing. This is the, I think we put that as the, the previous slide did mention this. Establish quality indicators for systematically monitoring and evaluating laboratory contribution to patient care, because that's the prime responsibility that we have. The other, of course, is also that you include when you are defining the TAT, of course, under the same thing, you will also describe in 4.15.7. It'll also mention that you will have to follow up these patients, follow up and define turnaround time after discussing with a concerned clinical team. Okay, you cannot say, okay, one whole day for a gram stain, or 1 week for my culture reports to come, because I don't know the organism when it will grow. But most of them grows, right? So you need to give some logical, reasoned out, evidence-based and discussed out turnaround times. Many labs will say, ma'am, our turnaround times never deviated, but they would have written turnaround times which are really stretched out. So definitely it'll fall within that, even if you want to make it. So it is not anyway helping your process. It's not helping the system as well, right? So what is the quality of a quality indicator? How should it be? How should the quality indicator be? It should be measurable. So measurable means, can you count it? How many deviations? Okay, can you time it? What time to what time? Can you record it? Do you have a capture of errors done, etc.? Are you recording? So all of these are measurables. Okay, achievable. Can you actually capture it? Do you have some mechanism of putting somebody to review it and capture these data? Is it possible or not? Is it done? Can this be done at all? If it's done, then you can definitely look into it. Interpretable. So once you get these numbers and you start to capture them, it will not make any sense if you don't make any interpretation of the fit. When you've got it, what does it mean? Does it mean you're doing well or you're doing poor? Actionable. Once it goes wrong, can you do something to set it right? Okay, is it possible to do that? Then that is a good one. And it has to be timed. So it should cover all those short-term measures and the long-term measures. And it should set to involve all lab personnel from top to bottom, from top down, everybody included in the process of. So that is why even in your training sessions, it's good to tell all your technical staff on the quality indicators, capture of these quality indicators, and what does it mean, etc. It has to be very balanced. Okay, does your set cover the full events of events? Does it cover all of that? When you have prepared your indicator, does it cover all aspects of your lab functioning? Okay, so what does enable 112 mention about these quality indicators in the evaluation and audit part of it? It says the lab shall ensure that analytical processes are also covered during its internal audit along with the other processes. Okay, the laboratory shall incorporate salient or important quality indicators for monitoring its performance. This shall describe the evaluation of various aspects of a laboratory function, such as, but not limited to the following, which is sample collection and identification, transportation and processing, analysis and reporting of results, turnaround times, complaints, equipment downtime, uncertainty of measurements, performance in PT or EQA schemes. So these are the things that is given as what you could capture as quality indicators that in each of these areas. Okay, but this does not limit you. If you have a unique scenario of setting in your laboratory, you can add more than what is there. Okay, these are very few limited ones. Okay, how to select a quality indicator? So like I mentioned to you, how a quality of the quality indicator is defined. Then choosing also will define, because some of the accreditation or regulatory requirements require some, not just NABL. NABH also looks at lab quality and looks at how many errors or redos and the diagnostic waiting time, and adherence to safety precautions in the laboratory. All of these are NABH requirement quality indicators, which needs to be captured every month and presented. So they have to be surely there. So it could be an accreditation or regulatory requirement. And these metrics should ensure continuous quality. Your capturing should say that. Then identify areas for improvement based on the customer or the stakeholder needs. Monitor specific and stable ones, like for example temperature. Your temperature is going always, your refrigerator temperature, okay, they are stable. Sometimes it could be some activity which is a complex process. All of these can lead to this, and I'm looking at that part of it. So you can monitor that also as a quality indicator. Or whatever you've done you've done some improvement, you've done an intervention, you want to see whether there is an improvement. So for your planned improvements, you're looking at effectiveness, then you can capture and you see that as a quality indicator as well. Okay. Then you can also explore potential risks. I'm sure all of you are those who have already been in these few sessions with Kaho earlier have been exposed to risk assessments. Risk assessment will always look at how often is it occurring, how severe is it, is there some kind of detection. So these three things are something that's going to be regularly looked at for you to see. Now, when you're capturing your quality indicators, you'll be able to have this. And so you are able to explore or look at your potential risks, so you know what you need to work for, or what are your mitigation plans that you need to have in place. So this is your next one that you have. Measures should have targets or goal established based on research rather than arbitrary values. Okay, you should not have just, okay, so your benchmarking should be something that is being worked upon, not something you say, okay, this is what I would want to achieve, etc. Okay, the good news is that the fewer the better. The best numbers to work on in any lab is 10 to 12 quality indicators. More than this, many times we've seen that these are only in papers, not happening. They are never discussed, their trends are never analyzed. Sometimes they don't get into the system for in any means also. So it doesn't help. So always choose the best 10 to 12, which will work very well. So this really requires a team to work. Okay, so you need to have a benchmarking for your quality indicators. Now, what is this benchmark? It's a standard or a point of reference against which whatever you have set, you want to compare and assess. Okay, so your lab is having this percentage of contamination of blood cultures. You want to compare against the standard. Okay, so the ASM would say 3%, less than 3% is your acceptability for contamination rates for blood cultures. So if you are having 10%, 12%, or 6%, or 4%, whatever percent you have, you need to know that, okay, now I'm going to work on this to see how I get. Or you are in 1 or 2%, that means you're doing very well. So still you know that you're better. So this is a standard point of reference against which limits you will set, compare it. Comparing your own lab data. So how are you capturing these benchmarkings? It could be in different forms. These 4 different ways you could capture. One is your own lab data you take, and you take it from external standards also, studying multiple labs and the best performers you choose. And for those which we don't have a defined benchmarking, so you take the best as would be described in some review articles, etc. So you take it up and see whether you are at least close to that one. So always look at your national benchmarking levels than international ones. Okay, because your national ones will try to address most similar, will have more similar issues of variables, and therefore it's easy for you to do that, and then you can move forward further. Okay, the CAP would also give certain tools for capturing these benchmarks, like Q probes, where you have the snapshot, or Q tracks, which does the continuous monitoring. That also would help in giving you or setting up the benchmarks for us. The other is literature based bench setting or benchmarking. As I mentioned to you, you look at literature and see what works best. And then sometimes the association, like I told you, the ASM would give you, or the CLSI would give you, your cutoffs. And then that can be used for as a benchmarking tool. Now, how do you prepare your indicators or your quality indicators? First, you're seeing, okay, what are you trying to measure? Then you look at the methodology. how to capture this particular data. Let's take turnaround time. How am I going to capture the turnaround time? Who or what to capture the data? Who's going to capture the data? Or what am I capturing, etc. So depending on what is the variable, how often to capture the data. Okay, is it going to be every time or this many numbers? If your numbers are huge, it's going to be in random selection of picking up some numbers, or it's continuously that you pick up everything. Then your limits or your benchmark that you would see, what is your acceptable limit? What is your concern value? What is your unacceptable limits or critical value? So what is that range in which you are supposed to lie? Okay. Then how are you going to present this quality indicator? Are you going to put it as graphical presentation of graphs, or it's going to be in text that you put it in tables? Interpretation, what does it mean to you when you get the contamination rate? Suppose blood culture contamination rate is 5%. What does it mean to you? What does it reflect in your quality? Does it mean that your bottles are not being preserved very well? Is it because they are not cleaning the site very well? What is that going to tell you? What are the unintended variables? Which means sometimes your patient actually has an infection with coagulase negative staphylococci, but we have probably considered that as a skin contaminant and say, okay, this is contamination free. So there may be something like that also. So you always need to be looking out for those which may not be the routine, the regular. Okay. So action plan, what will I do if it indicates acceptable performance? Okay. So, what am I going to do when it's well within 3% of contaminations of blood culture? Or what am I going to do when it is 5% of contamination? What am I going to do when it is 15% of contamination? So what is that I'm going to do is my action plan. So like risk assessment that we plan out, it's always before we start that you plan, okay, if this goes very well, I'm going to do nothing about it and I'm going to monitor further. But if it's good, not so good, then I'm going to be monitoring this and I'll be looking at these things. When can I stop measuring? That's an exit plan. So if the 8 steps in the quality indicators setting up, the exit plan also is important, where now it's all kind of standardized. After a period of time, they work as if they don't even need to see what's happening, and it just flows. Unless there is a new person joining, new machine, new equipment, then you need to rework. Otherwise, some of the processes gets very well straightened up. Okay, I can tell you of experience of handling this blood culture contamination. We did as an audit. In fact, one of the postgraduates did it as a requirement of a clinical audit. So the rates were higher, and we found that certain of the captured values, we tried to put it on and see which area are they going to be, and we found that the emergency department and certain areas in the hospital had more numbers, like 13%, and some areas were only 1 to 2%. Like the ICUs were fantastically doing very well with 1% or so. So when we put them all together, it came up to 8%. Then we started to work. We did structured intervention by training people, put them with mannequins and teaching them, watching them, putting supervisors to check them. Every time there is a contaminant, we call up and tell them, this is what happened, etc. So please be careful next time, like that, without being harsh on them, but at the same time telling them, so that it kind of reinforces the need for the required activity. The big secret is to have, for the entire quality indicator team, is to engage people who do the work. Most of the decisions are taken by people who really don't do it. Okay, sometimes I feel when you start higher up in your professional hierarchy, you kind of miss out on the actual joy of doing certain things. Okay, but it's good to sit down and talk to the folks who really do the work and say, okay, where is it going wrong? Okay, so the heads, okay, they have kind of create this, I am finding less time to handle these issues. So I don't think that should happen. You should sit together as a team and work and see what is going wrong where, and what needs to be addressed, and how this can be done. And when you make various, you can have all your options of quality indicators. You can choose your top 10. okay, and then work on them. So that will be a best way of doing your quality indicators, rather than just randomly picking the easy to do, or the one which does not give you any issues. These are few examples. Of course, the Clinical Microbiology Review 2018 is a very beautiful document that you should all refer to. This is looking at the entire quality management systems, okay, of a lab. It's a beautiful document. It gives you a lot of things, and of course I have added one or two things additional to what is there, because that went in a beautiful flow, and just for completion I've added, of course, but the main content was from that document. Okay, pre-examination phase, look for incomplete test request form. How many of the total, you take the test request form for a period or a particular day. So we used to do this. In fact, one of the students also did this in audit, where you do look at completeness of the test request form. So in completeness, what do you mean by completeness? That is what requires standardization. Everything is filled, only you call it complete. But somebody will say, oh ma'am, all these are there, so probably this is complete only. This kind of gives everything. No, that is not how it's supposed to be. Everybody who captures should capture it exactly the same way. So you look at incomplete test request form as one. Sample rejection rate, how many of your samples are getting rejected? Okay, if you should have, first of all, a good sample rejection criteria defined, and then you set it up and to do it. So you need to look at the sample rejection rate. Then you also look at the hemolyzed samples or wrong samples. Okay, hemolyzed samples are one of the highest scorer in the pre-analytical or pre-examination variables. Okay, they've looked at the sampling in the whole of a laboratory. So entire lab, a lot of samples will be received for biochemical test, and pathology labs would also receive samples, blood samples, serum sample, plasma samples, also is microbiology lab samples. Hemolyzed sample is supposed to be one of the top scorer in the errors in the pre-analytical. Okay, so the others are like wrong sample, insufficient sample, wrong identification, informed consent not available for HIV test. You look at this is all that we discussed in the pre-examination variables. All of them now becomes your quality indicators, looking for complete test request form, rejection rates, percentages of hemolysis or error rates. Okay, and then insufficient sample or inappropriate sample, wrong tests, wrong samples, etc. In examination phase, you look for random errors being done in testing, repeat testing that's been done, okay, repeated for various reasons. Then contamination. You can have your blood culture contamination, where your healthcare professional need to be retrained or looked at other causes of contamination of the bottles, etc. The other is urine sample contamination or inappropriate sampling, where you have more of a mixed urethral flora being grown in your cultures, where your patient need to be educated better. Proficiency testing performance evaluation, where you need to see whether your equas have failed or passed, and what percentage have you got in all of these scores, and how do you need to improve on each one of them. Okay, accuracy of point of care testing. Okay, if you have some point of care testings and in your hospital, in your site labs, maybe for simple tests that you would do, how accurate are these tests when they are retested later, when they are sent as an interim report and then later retested, how good these are? That could be an excellent indicator as well. Correlation between the microscopy and culture. What you have done in microscopy and what has grown in culture. What is the percentage of correlation that you would see between your microscopy and culture, the gram stain to culture? Post-examination phase, your critical alert reporting. How early are you defining your critical alerts clearly for each of your tests? Does it have a critical alerts defined? And if your alerts are defined and you have listed it, then you should be able to communicate whenever there is a critical result that has appeared. So this critical result that has to be reported within a defined time period. And there is a particular way of communicating to the person concerned, so that there is an action taken on the critical values so that the patient gets benefited. So it's just not a critical alert reporting. It's just more than that. You need to look at the values being documented. You are able to communicate it to the concerned person, and you are also doing it in a timely manner. So this is, all of these are together. Okay, so it has to be within 60 minutes. Okay, that's a good thing to do. So you need to have a robust system of doing that. Then turnaround time, like I mentioned to you, your entire lab's turnaround time it's going to be dependent on how well you capture your timing. of request coming. It's usually a turnaround time means from the time the clinician asks for the test to the time he receives the report in his hand. But most of the time, what we look for is a diagnostic turnaround time where you have received the sample in the laboratory and performed the test and you have sent it out of your lab. So this is what you're capturing. So it's a good thing to capture the whole so that you see multiple other variables also and address it, or you just focus at your lab and start working on it. If it's a standalone lab, it becomes easier that way, or look at what more can be captured in this. Remember and look very critically whether are you capturing the collection time, are you capturing the receiving time, are you capturing the reporting time, and are you capturing the release time. So is this capture being right in its way of communicating in your turnaround time that you do? Okay, so you should also look for those urgent tests and to that of your regular routine test. Then there are something called as esoteric tests, which means rarely done, tests. Those would be your esoteric tests. So for them, what are your turnaround times? You need to have defined turnaround time specific for your routine test, your urgent test, and your esoteric test. So all of these have to be written down. Incorrect results because of some LIS issues or failures. How often have you given a wrong? So that means I'm sure all of those who've gone through an accreditation process must have faced this question. So have you done a verification of your LIS? Have you validated your LIS? Because you believe your LIS is giving the right report. Suppose it's got crisp cost and wrong report has been released to some patient, and then it could be any report of concern, and definitely a intervention taken based on that. All of that is going to be a problem. The other is your transcriptional errors of the reports that have been released. So that could be yet another beautiful quality indicators. How many of them would be your manual transcriptional errors that we do? That can also be a good quality indicators. So you can choose any of them. These are the technical ones. So these are the non-technical quality indicators. Okay, those are related to safety, like I mentioned to you. Safety. What are the percentage of people adhering to safety requirements, or how many of them have suffered needle stick injury, how many blood body fluid spillage did you have, how many people acquired how many people acquired infection working in your laboratory. Okay, so these things, so unless you capture them, you're not going to be able to find them out. Okay, percentage of personal records of competency assessment, that's one of the example. Environment, number of episodes of room temperature exceeding the acceptable range for performance of the test, particularly serological test. You always look at the room temperature. Molecular test, you look at the room temperatures. Equipment downtime, what percentage of your equipment had had issues, and how many days did you have of your equipment being down, okay, in your entire of your working. Supplies and inventory, number of back orders for critical reagents affecting patient care. How many times have you, for those critical reagents that you had to do the back orders. So that's another thing. Customer satisfaction, of course, both your client, which is your patient, you ask the patient about the phlebotomy, the waiting time, and the experience of testing, the report being on time, etc., etc. So you actually ask them to give you a feedback, and then you capture them. The other is your physician feedback. That's another something that you need to. Then is your technical staff, or the staff feedback, the lab staff feedback. All of those are important. These are the lab staff don't become your customers, but definitely that's another feedback that's very useful, and they would give you good feedbacks of the testing, and that is useful, right? So how do you assess these quality indicators which has been in use already? Is it important? Scientifically acceptable? Is it feasible? Because whether the implementation would require too much of training and cost, etc., or not. Whether it is useful because it is comprehensive. Does it capture the different phases of the lab testing? Okay, all of that. So we need to have these quality indicators. How do you present these quality indicators? So you need to do a trend analysis to see what was it last month, what is it now, what do you expect it to be the future. So comparing one time period to another. Today it is here. Tomorrow, what do you want to be? In always all issues related to all metrics related to issues, you always want it downtrend. And all metrics that is related to compliance to good practices, you want to have a uptrend. So always look at where you are to where you want to be. So this something, so your benchmark is where you want to be, and where you are is where you are already. And you should look at month to month to see whether you are improving. So you compare from one period to another, one group to another. You will be able to do some future projections also for assessment of our outputs, comparing with your standards as your benchmark, comparing with the other organizations. So you can do this, you should be doing this trend analysis and then analysis. Again, the same document also gives this as an example. I think you should go back to see this document. It's beautiful. It kind of gives you how you review this. So collectively, you can look at single, for example, the blood contamination rate. So let me take you. So it is going to look at the pre-analytical or the pre-examination phase in your quality management system. How frequently are you going to see it? Quarterly, every quarter I'm going to analyze it. What is my benchmark? It is 3%. Then who are the stakeholders? It's the nursing staff, because they are the ones who are collecting the sample. So they need to be appraised of when things are not doing well, or if we and appreciate them for when things are doing well. So similar. So you could have multiple such things related to blood cultures completely as a full set, and you can do as a collective comprehensive also. So you can do individual and also multiple things together for each one. So similar is these examples on MDR statistics, surgery gram stains requirement, and surgery tissue and fluid ratio, then critical value statistics that you are giving them, and then rejection rates, what percentage is acceptable, how often do you evaluate it, then collection corrected results, how many error report that we have corrected. This is going to be multiplied by 1,000. Okay, number of errors by total number of tests into 1,000. Okay, that's how you give it. Then they also the events details, like specimen labeling, all that, so you capture this, and you also put the improvement, whether it is close to the target. You give a blue line, needs improvement, then that's a different color, then red, out of range. So you also know whether you're doing well. So you can put, this is a good dashboard that you can have to capture. This is again an example that's given in the same manual. Okay, this is just another example that I thought collectively to put all of them together. So for example, what percentage would you call as that should have 8 to 10 ml of blood? At least more than 80% of them, of the samples that you're collecting in your lab, should have 8 to 10 ml of blood. That's a good thing. If you're not doing, that means you have to work on it. Otherwise also you can still work on it and bring down to 100%. If how many of the laboratories, how many of you are getting samples more than one blood for a patient suspected with sepsis? You need to get at least 90% of your patients with at least more than one blood sample collected, at least 2 sets. And how many of them are getting it? Your contamination rates of blood culture should be less than 3%. How many of them? And how early are you reporting your gram stains to your clinicians whenever it's flagging positive? If blood culture flags positive, you do a gram stain, and that gram stain has to be informed to the clinician as early as 1 hour. 1 hour should be the ideal. Remember, your critical alerts, your communication, all of these should be within the 1 hour to the concerned person, so that they make a decision. And this has to be also related to the correlated with the culture later, to see whether they are matching what you told in the gram stain. So you told gram negative organism, and what grew was gram positive cocci or the staphylococcus. So you have to see whether it is correlating also. And you also see equals results where at least it should be passing with more than or equivalent to 97% of the time. So this is just an example, okay, that has been given. So you can also choose any other and then start to work on them. So this will be my last but one slide, I think. So this your take homes for today is pre-examination variables are very unique to microbiology. We need to have vigilant action, and we need to have people very well trained. We have to anticipate these things could go wrong. Okay, so anything can grow anywhere. Your fungi can grow in any of your cultures. So how do you know it's coming from the sample or otherwise from the environment? So you need to look for that also. So you need to be very watchful of what is happening and look at it. So you need to understand your entire lab process and systematically work on each one of them and see how you can address each of these variables. Quality indicators and metrics are an essential component of our total quality management system and your process improvement in the laboratory. You should use some smart quality indicators which may be used within the laboratory. Prioritize your quality indicators and study them and define the frequency. So prioritize your 10 to 12 that you choose of the entire lot. What works or what should work in your for your lab, you should define them and then put them clearly, and then you prioritize based on what is that you need to work on, etc. And then you define the frequency, whether you want to do monthly, you want to do quarterly or annually, depending on the type of quality indicator. Of course, annually will not help you, at least monthly and quarterly, and then see what is and it's important to review your quality indicators and see that whether you want to continue the same quality indicators. If things have worked very well, then you move on to the next ones that you need to work on. Okay, so then you look at the action, what need to be done when things are not going well, when you're not at the benchmark, when you're not at the optimal required. So what is the intervention that need to be done? What is that improvement activity that needs to be implemented as an action plan? And how do I follow? When I follow up, and that means I need to further capture the quality indicators to see the trend of raising contamination coming down. Okay, that gives you a real happiness and satisfaction. Okay, so this would be the last one. So if you can't measure it, you definitely can't manage it, and that is Peter Drucker's quote. So thank you very much to all of you for your patient listening. And if there are any queries or questions, and if I'm able to answer, I'll be glad. Thank you so much.
Thank you so much, Dr. J.Jayalakshmi. Indeed, it was an enlightening session, and there are many things about microbiology, which as a biochemist today, even I have learned, thanks to you. And ma'am, there were a few queries here and there on the chat message box. One was by Mausami, where she's asked how to create a lab ID as it is generated by the lab and not by the LIS software. So if you could just answer this question, ma'am.
Lab ID meaning?
I think so. What her query is that there are many organizations wherein they have a separate UHID as well as a lab ID is generated separately. So there's always going to be a confusion between considering the turnaround time. I think so. It's what Moshmi is actually concerned about.
So, Dr. Moshmi, I'm not very sure of what the question is, but I kind of understand the concern that you have regarding the labeling your samples, right? It could be a sequential labeling of your samples. You can define it. So some of the laboratories have a automated sample labeling. Okay, so they are automated by the system generates a number and gives. So you can follow that, or you can give a sequential number. It's very simple to give. So you automatically give the next number in your lab ID, and that is what you should be capturing. So even in your identifiers, whenever you have a patient, like I mentioned to you, you could have the wrong sampling done. You have two Uma or two Ganesh or two Parvati or somebody, two patients in the ward, and you accidentally took the wrong sample of the wrong patient. So you could have used two identifiers, not just one. Okay, not just name, then also the UHIDs that you have. This is in a hospital setting. In the laboratory setting, when you have a patient sample come in, your system generates itself, and then you have a sequential number that you have in your laboratory. So that should be useful, I guess. If there's anything else more, Rajendran sir, you can help us understand this question.
So what I feel is what Mosmi is asking is basically on an LIS in a standalone laboratory and not of a hospital UHI.
You will already have a generated one. No? It gives you a number already.
Yes. So in case if they are doing it manually, if they are doing it manually, they can have a policy of having a proper numbering system. Like many of the organizations where I've seen it, they put the first two digits, which are the year, the second two digits, which are the month, and then they start continuing with the rest of the digits, which can be start from 0001 and so on, depending upon the number of samples per month in that particular laboratory. So that can also be worked out.
Yeah, that's something that our lab used to do that. So, you know, the year when it starts, you start, because you know how many numbers you will get. So you start the year, and then you start off with 0, 0, zeros, you know, 5 zeros or 7 zeros, and the last number would be 1, and starts off with 1, 2, like that. So depending on the lab load that you have your numbers added. So yes, sir, Rajendran, sir.
You can add a two figure also. The section also you can add. The section
Correct, sir.
and the subsection is also add, so that the sample can be traceable in the future for the which section, which sample, and which month and which year. So that will be easy. The MRD number or HMIS number, the main UHID number is for the, you know, for the data collection for the hospital. But you have to give the lab number for your own traceability and to take out the data of your laboratory.
Yeah.
That is what I just wanted.
Perfect, sir. Super.
Thank you,
That
sir.
is why we need you.
Yeah.
Yes. Dr. Achwat Gauri has a question on how will you collect the urine sample for culture in catheterized patients?
Okay, it depends on how, so catheters would also have a port for collection. So you could collect it from the catheter port for sample collection, or from the tubing. Okay, you clean and then you draw the urine from the tubes also. So both ways you could collect the sample, never from the bags. So that's the most important thing that we need to understand. Yeah.
Dr. Sunitha has a question: how to analyze the TAT in lab, especially in microbiology and histopathology?
Okay, like I mentioned to you, the turnaround time is going to be, you have to define what is your turnaround time. Are you going to take the total test turnaround time, or your diagnostic turnaround time, or a clinical turnaround time, the entire from the sample to the report to, or your diagnostic test turnaround time alone? And then you will also define, you should be able to capture these points, these critical points of sample collection, sample receiving, sample reporting, okay, and then release of report. So all of this have to be captured. So you will have to see the difference. Sometimes only when you walk through your process, you will know what they have written down as a collection time is not the collection time actually. Sometimes it is the billing time, like I told you as an example sometimes back. Also, sometimes it will also be your the receiving time itself is taken, the sample receiving time is the same as the collection time. So the collection time is 12:01 collection time, and 12:01 is the receiving time also. But they would have brought the sample from elsewhere. So these are something that you need to look at.
Okay, ma'am. I think so. All the queries have been answered very well by you. Thank you so much,
Thank
Dr.
you very
Jayalakshmi.
much.
And thank you so much, Dr. Rajendra.